In responding to the topic, there's been a lot of changes. Even growing up here in Nebraska, between the 1950s and 60s and where we are today, and I wanted to just spend a little time talking about how much things have changed over the years, but at the same time give people some background on the whole area of intellectual disabilities. And first question we're asking or being asked is who are people with intellectual disabilities? And frankly, they are your neighbors, they're your children, they're your relatives, and they make up potentially 2 to 3% of the overall population, just based upon statistical norms. Your neighbors, for example, there are group homes all around the Omaha area, for example, right now. There are individual living arrangements for people with disabilities all around the Omaha area. There are supported apartments all around the Omaha area. So your neighbors basically are right down the street. You may find someone with an intellectual disability. Your children, okay? We don't know the causes of approximately 60% of intellectual disabilities at this point in time. They're just unknown. But we do know that, again, 2 to 3% of the population is going to develop some type of intellectual disability or be born with an intellectual disability. Your relatives or family, okay? Almost all of us, if you look around the room, somewhere in your distant relations or close relations are probably going to have somebody with an intellectual disability amongst them. Where does this all come from? Well, it all comes from primarily probably the best source for intellectual disability is the American Association on Intellectual Disabilities, Developmental and Disabilities. American Association on Intellectual and Developmental Disabilities. This is a new title for this group, and just getting used to it is a challenge. The 11th edition defines intellectual disability as characterized by significant limitations both in intellectual functioning and adaptive behavior as expressed in conceptual, social, and practical adaptive skills. The disability originates before the age of 18. This came from AAIDD in 2010, just in June actually. This was from a presentation done at their national conference. So one of the things about this organization is that it started actually in 1921 as the American Association on Mental Deficiency. This is the original title. There were a number of revisions to the classification definition, and in the 5th edition in 1959, the term was changed from mental deficiency to mental retardation. And at that time, also, individuals with IQs at that point as high as 85 could also be diagnosed with having an intellectual disability. And the emphasis at that point in time was on classification. So we had borderline IQ individuals. We had mild mental retardation, moderate mental retardation, severe mental retardation. And basically what was happening is services were being given to individuals based upon what their the classification was. For example, in schools, individuals with moderate mental retardation, again, the label used at that time, were thought they can't read. We can't teach these people to read, so we just won't bother to do that. And we know that kids with Down syndrome generally are in the moderate range, so we just won't teach kids with Downs to read. And that was kind of the thinking at that point in time. We have you'll be seeing a number of fishing trip slides here because we have as part of our AmeriCorps project, we have something called SANS. It's Sportsmen Assisting the Nation's Disabled Sportsmen. And this is from several of our events that we've put on over the past year. So if you see a lot of rod and reels, I really don't get a kickback for these. The 6th edition of AAMR's definition at that point in time lowered the IQ back to 70, and it was increased back to 75 in at the following edition. And then in 1992, there was a major change. And the emphasis in this particular grouping of classification documentation was emphasis on support systems. In other words, defining adaptive skills and how people's positive skills interacted with their environment, not just upon an IQ score. In the past, back when I was in graduate school, when the Earth was still cooling, at that point in time, IQ was basically the only thing that was used to define whether a person had intellectual disability or not. In 1992, the emphasis started looking much more at adaptive skills, looking at what kind of supports individuals need, and what types of supports would actually keep people from being classified as disabled in certain contexts. Because some individuals, having skills in particular areas, may not be considered disabled in particular jobs, and in particular vocations, in particular roles in society. Again, in the past, there was a cutoff score, and the cutoff score was considered to be significant, and that basically meant two standard deviations. For those of you who have some statistical background, what that means is an individual's scores on an intellectual IQ test or an adaptive behavior skill test would fall in the bottom 2 to 3% of the population. So that it would be significantly lower than the quote average, which would be at the 50th percentile. And that's kind of the thinking in terms of how you use measurements with this. The term intellectual disability has been introduced and the whole organization, AAMR, has now changed its name to the American Association on Intellectual and Developmental Disabilities. And the whole concept now is changed towards avoidance of the term retardation. Frankly, it's somewhat of an uncomfortable term. It's a term that you've seen children use to try to hurt each other's feelings, that type of thing. And doesn't really emphasize the fact that this is a disability. It's not necessarily something that makes the person deficient or retarded in certain areas. Individuals who had the definition, or met the definition of mental retardation today all still meet the definition for an intellectual disability, except now the 2010 multidimensional classification system looks at 5 areas: intellectual abilities, adaptive behavior, health, participation in activities, and the context of the disability. And I'd like to go into that just a little bit. Another outstanding fisherman. The framework for assessment in terms of making a diagnosis. Why do we do this? Okay, well, first of all, we need to establish the presence or absence of intellectual disability in terms of eligibility for services. Secondly, eligibility for benefits. And thirdly, to establish eligibility for legal protection. So individuals with the diagnosis fall under these categories, and it's one of the main reasons that we really have to go through the diagnostic process. Primary purposes were for eligibility, again, research. How do we address, are there certain types of intellectual disabilities, for example, where we can identify conditions which might have caused that disability, or genetic concerns that can be addressed. Ways to, for example, with PKU, to keep individuals from becoming intellectually disabled. Phenylketonuria. So there's different ways that we have been able to use research data to keep people from becoming intellectually disabled. And then most recently, the provision of appropriate services and supports is the emphasis that we are pushing at this point in time. Trying to identify the needs of individuals for supports to be able to fully function in the community, and at the same time provide them with the supports that are available to them and to which they have entitlement from our society. So, the most important assessment function is planning, implementing, and evaluating systems of supports in the new definition. So one of the things that we're emphasizing today is, how do we do this? AAIDD has developed a conceptual model for this, And it has several components. The first component is identifying what the experiences and goals of the person are. Secondly, the intensity of support needs that that individual or those individuals need to meet those goals. And then develop an appropriate support plan, which would include progress monitoring, evaluation, and then based upon potential further needs, we move back up the ladder, start all over again, and help the person by revising, looking at their current needs and their directions, and then coming up with a revised plan for them. As the field moves to a more ecological focus, meaning that in essence what we're talking about are what are the environmental influences on individuals with disabilities, on intellectual disabilities. How do we make sure that they get included in the mainstream of life, or mainstream of society? And the multidimensional classification system, again, emphasizes intellectual abilities, adaptive behaviors, health, participation, context, and the intensity of supports that are necessary. This is Jonah and the whale. As you can see, this is there's actually a fish in there if you look real close. The supports model has been basically with us for now almost 20 years. And it really was emphasized much more in the 1992 definition. It's still there, except we're moving forward with it at this point in time and looking at expanded use of support as how do you define what resources an individual with developmental disabilities or intellectual disabilities needs? How do you determine that? And using the assessment process to determine supports, and then in turn, how do we get the resources that are needed for those supports? So we're separating case management from direct support provision, focusing on person-centered organizations. In other words, how do agencies individually foster placements, or how individually foster the services that are, or the supports that are necessary. In many cases in the field, there are slots, okay? So there's a group home slot. We know it's out here in Cozad, Nebraska, and we have an opening. So it doesn't make any difference if it's a square peg or a round peg. That person, if they want the service, has to fit into that particular slot. Those days are going, and hopefully in the next 10 to 15 years they'll be gone, and we will be looking much more at individuals and what their desires and needs are. There's a continuing emphasis, especially given the economic climate that we're in today, on the use of natural supports. In other words, not just paying for services. Services are extremely expensive. If you take a look at the national averages for institutional care, by way of example, the average is $205,000 per person per year to place an individual in an institutional setting. It's much less than that in the community settings, and even at that, we're still looking at somewhere in the neighborhood of $50,000 to $70,000 for an individual to be placed in a group home. Taken as an alternative, placement in the person's natural environment, in their home environment, with family supports or relatives, or some support where an individual comes out and helps out with bill paying, or with helping the person balance the checkbook. Much less expensive, number one, and number two, focuses much more on the natural contingencies, natural environment. Finally, the use of improved technology to assist individuals to modify and manipulate their environments. Mike Leibowitz talked about some of the different technologies that have been helpful for individuals. Adaptive technology, some of the devices that are available, for example, for individuals with Lou Gehrig's disease, weren't there 15 years ago, and allow people to continue to be able to communicate.